Ladies and gentlemen, please stand by. We're about to begin. Good day and welcome to the Foundation for a Healthy Kentucky Health for All webinar. Today's webinar is being recorded. At this time, I'd like to turn things over to Ms. Rochelle Seeger. Please go ahead, ma'am.
Thank you so much. Hello, everyone. So glad you joined us here today on a hot summer Wednesday for our Health for a Change training series. Again, my name is Rochelle Seeger. I know I've met many of you out and about across Kentucky, but I'm so glad you joined us here virtually today because we have two fantastic people from the Prevention Institute to share some of their work with us, and I'm very honored to have them on the call today. So again, I'm with the Foundation for a Healthy Kentucky. We're a nonprofit philanthropic organization created in 2001 with assets from a settlement agreement as a result of the merger between Anthem and Kentucky Blue Cross and Blue Shield. The Foundation for a Healthy Kentucky's mission is to address the unmet health care needs of Kentuckians. The Foundation does that by a number of ways. One, we work to develop and influence policy, improve access to care, reduce health risks and disparities, and promote health equity. And that, I'm excited to say, is the topic of our webinar today. This Health for Change training series, the Foundation for Healthy Kentucky, began in 2011. And what happened at that time is the Foundation had some grantees, and the Foundation was offering technical assistance to those grantees. But when we looked at the bigger picture of what was happening in Kentucky, we thought it made complete sense to offer these trainings not just to people who had received grants from the Foundation, but to open them wider to the whole Kentucky community. So I'm so glad the Foundation has continued this training series year after year. The training series Health for Change has reached people just like you in all 120 of Kentucky counties. So I'm thrilled to organize this event for you today and the whole Health for a Change training. We have great things upcoming. Today's webinar, of course, on a really important topic of health equity with the Prevention Institute. I'm thrilled to bring you that. Next up, we have a webinar on August 1st on Kentucky ACEs, Adverse Childhood Experiences, where we'll have a team from the Louisville-based Bounce Coalition, as well as Dr. Connie White from the Kentucky Department for Public Health sharing ACEs data for Kentucky. So please do join us for that date. You see the other great webinars and workshops that we have upcoming. That August 16th, Working with the Media workshop will be held in Bowling Green, Kentucky. And on August 22nd, I'm excited to have Ben Summers from Harvard University talk about some of his research on low-income Kentuckians and their access to health care. So please, all of these are free. Feel free to share those with your neighbors and friends and like-minded people who would want to join us. The full schedule and registration is available on our website, healthy-ky.org. Also, you can find there this afternoon the slide deck from today's presentation, as well as recordings of all of our past webinars. We share those, and those are up for free on our website. One more announcement before we get started. In September of this year, the annual Foundation for Healthy Kentucky BOAST Memorial Health Policy Forum will be held in Lexington on Monday, September 24th. The theme this year will be Kentucky's substance use epidemic, a solutions update, and that event is free, but you will want to register. Registration is now open and filling fast, so you can do that at the registration site regonline.com/BOAST2018. So I please hope you can join us in September in Lexington for that event. Again, the Foundation's website, our social media, I tweet out of Kentucky Health Facts and run the Kentucky Health Facts website, in addition to working on this event, Health for a Change. And I'm thrilled to have Prevention Institute two trainers, Maureen Silva and Laquana Williams, here from Prevention Institute to share their fantastic work with us. Welcome, Maureen.
Thank you so much for the warm welcome, Rochelle. We appreciate you allowing me and my colleague to come back to present on behalf of Prevention Institute. As many of you might know, we had a chance to dip our toes in the water, so to speak, on this important topic back during our June Health for All webinar that we presented on. And our goal then was to introduce some of the core concepts of health equity and tools for addressing the community determinants of health. And so today we'll be doing a bit of a deeper dive discussing our report and framework, Countering the Production of Health Inequities, which applies a systems framework to achieve an equitable culture of health. And so we know that there are lots and lots of efforts underway that have started to be more intentional about defining equity and those connections around inequities that we see and experience around health outcomes. And so we'll talk about this framework as a way to ground our work more for achieving equity and advancing community health. So I wanted to introduce myself, and for many on this webinar today, I might actually be reintroducing myself if you were part of the webinar a month ago. But my name is Maureen Silva. I'm an Associate Program Manager here at Prevention Institute. My main area of focus is on chronic disease prevention with a specific focus on healthy eating and active environments. I work with communities both locally and across the nation to provide training and consultation, allowing folks to move from a very kind of programmatic, service-based education lens to thinking about the root causes of poor health from a policy and systems change lens. And I also wanted to introduce my colleague, Laquana Williams, who will be co-presenting with me. Laquana, do you want to just say a couple of words about yourself?
Sure. Thanks, Maureen. Hi, everyone. As Maureen mentioned, my name is Laquana Williams. I am also an Associate Program Manager here with Prevention Institute. My background and my focus here at PI is specifically related to health equity, both internally as well as externally. And so I'm happy to be here today to share some information with you all.
Great. Thanks, Laquana. And so for those that didn't have a chance to participate in our last webinar, we did want to put our talk into context today, first by sharing a bit more about our organization, Prevention Institute. We're a national nonprofit organization based in California. This is a picture of our Oakland headquarters. We also have a broad range of staff that kind of span from violence prevention to mental health to healthcare, nutrition, and land use planning. But no matter the experience of any given PI staff, we all have something in common that brought us to Prevention Institute. Most of us, in different ways, have observed through our own professional or sometimes even our personal experience that to be truly effective in advancing community health, we need to be thinking about an upstream lens to kind of get to these root causes. And so together as an organization, our objective is to grapple with some of the more difficult questions and help organizations think through these questions, which are, how do we do quality prevention that prevents illness and injury in the first place? What are some of the more impactful strategies for achieving prevention and health equity? And how do we do prevention work in a way that recognizes the interrelated nature of health and safety issues, and how do we break down some of those silos? And we answer these questions by tracking research, by offering a set of tools and frameworks, and then being able to follow that with training and consultation work to be able to build the capacity of the field and expand prevention efforts. So with that, I did want to share our webinar objectives for today. We'll be kind of thinking through and learning about some of the key conclusions that we'll be sharing from the Countering the Production of Health Inequities report and the corresponding framework. We'll also be examining and discussing the underlying community determinants of health and highlight the different ways that historical and current policies, practices, and procedures have in consequence produced inequities. And then we'll be identifying the different strategies through a system of equity lens for working across sectors to advance equitable community health outcomes. And so before we get into the nuts and bolts of our webinar today, I did want to do a little context setting in terms of being able to pan out and think about an important question that might come up a lot in some of our work, which is, well, what do we actually mean when we talk about health equity? We hear the term health equity a lot. It comes up in our grants, in the language that we use on a daily basis, in talking to other public health professionals, and hopefully we're starting to ground our equity-based practices in some of our thinking and our approaches. But how do we really define it? And there's a lot of definitions out there, but a definition that we reference that resonates with our team here at Prevention Institute is from Paula Braveman. And what she notes here is that health equity means that every person, regardless of who they are, the color of their skin, their level of education, their gender or sexual identity, whether or not they have a disability, the job that they have, or the neighborhood that they live in, has an equal opportunity to achieve optimal health. And I'm sure many of you, through your own work, have other definitions or statements that kind of resonate with you, but that's something that we come back to a lot in thinking about our own work and the communities that we work with. So given that definition and thinking about what you might already know about health equity, we wanted to pose the following question back to you all on the webinar to kind of get us thinking a little bit more about equity and how that applies to your work. So if you were to reflect on the types of images that you think of, what comes to mind when you think of a healthy, equitable community? So take just a few minutes, there's no right or wrong answers here, to write into the text chat on the left-hand side of your screen and really think about images, different things that you've seen or heard about that comes to mind when you think of a healthy, equitable community. These can be images of frameworks, they can be images of photos that you may have seen in your own communities or things that you've really seen that represent an equitable community in your work and beyond. But I just encourage you for the next 30 seconds or so to just write that into the text chat. We know that it's in the midst of summer and summer vacation, so this is also a good warm-up activity to kind of get our brains flowing here. So just take a few minutes. I think I see a few folks typing. So I'll give it just a few minutes here. So I am seeing active people, healthy food resources, ability to apply for or buy medical. Absolutely. So there's a few things happening here in terms of healthy and active communities. That's a great response. What else is coming up for folks? Give it just another few seconds here. I know that this is a tricky question. There might be a lot that's coming up. Fitness park with equipment for all ability types. I love that. All ability types is key here. We want to be thinking about populations across the lifespan as well as different levels of ability. Wonderful. Other pieces that are coming up. And this can span anything from activity to violence prevention strategies to safety and so on. I'm also seeing bikeable paths, equal access to vegetables and good food choices, public transportation that's affordable. These are great opportunities for communities to foster intergenerational relationships through volunteerism, community events, gardens, etc. These are great responses. Thank you for participating. And this kind of gets us to some of the pieces that we'll be talking about today. We know that education and services are key, but we really kind of want to get to what it looks like to create and foster equitable community environments. And we can do that through a number of ways. We know that protected bike lanes, also designated sometimes as cycle tracks, are best practices for age-friendly cities. This allows folks to be able to ride when they're young and starting out and when they're older, so they feel protected being able to bike in their own city. We also know that farmers markets have been known to be a great source for increasing access to culturally appropriate fruits and vegetables for lots of different communities. And they can also act as social hubs, which is something we're seeing more and more pronounced in some of the research. So it's not just about fruits and vegetables alone, it's about creating a space for people to congregate. This is a photo from the Inglewood Farmers Market. that launched as part of a pilot program a couple of years ago. This is a community in Southern California. And this was something that was a huge need for this community and had been asked for decades. And finally, with a lot of grassroots organizing and advocacy among community-based groups and residents, they finally got this market approved by the city. We know that public spaces like parklets, plazas, playgrounds, and so on are key to advancing equitable communities. We see more and more that there's this connection here to safe, equitable, multi-unit housing and creating green spaces either on or near the property and gathering places for people that live there. We also know that age-friendly, walkable neighborhoods is an opportunity for residents of all ages to start and keep healthy habits that increase mobility and reduce things like isolation. This image is really important to me because I think a lot of the time when we talk about creating walkable communities, for instance, we end up putting in really beautiful crosswalks that end up having 20 seconds. And a lot of our aging populations have come to the table and said, we can't walk across the street in 20 seconds. So who is this really for? So it's important to be broadening our scope and really thinking about the community that we're in and the needs and the priorities that are being informed by communities. So in essence, we can see here that there's increased attention to the connection between health and place, and this is for good reason. We know that a livable community is safe and secure, has affordable and appropriate housing, diverse transportation options, and supportive community features and services for residents and families across their entire lifespan. And so this has sparked a surge in a lot of initiatives designed to improve health through community environments, with attention from lots of different sectors and philanthropic partners that are making these community investments to support health and equity. And you know, the other piece that we wanted to kind of bring up here is that at the same time, in light of so many of these improvements that we're starting to see both locally in our own communities and as part of national efforts, we also know that we cannot adequately address the root causes of poor health without looking at the inequities that play out and are persistent in so many of our communities across the U.S. And so this quote is from a Prevention Institute publication, A Time of Opportunity, and it notes that people's health is strongly influenced by the overall life odds of the neighborhood where they live. Indeed, place matters. In many low-income urban and rural communities, whole populations are consigned to shortened, sicker lives. This image is a good representation of what this quote means. This is from a campaign supported by the California Endowment a few years ago, and these billboards were displayed in communities across California to demonstrate that our life expectancy is correlated with our zip code. And this may not be new to many of us. We see this a lot, and I'm sure there are similar campaigns or initiatives that are happening throughout. But in other words, where we grew up and where we live, these inequities we see play out in different ways. So on the left-hand side, this boy lives in a zip code that represents a neighborhood in South Los Angeles, which is a community that is predominantly low-income, African-American, and Latino, whereas on the right, this boy lives in a community called Palo Alto that is a much more affluent, predominantly white community. And we can see here that there's a 14-year age difference, and this comparison isn't just novel to places in California. We see this trend happening in places across the U.S. And as I mentioned before, I'm sure many of you might be nodding your head or sort of looking at this saying, yes, this is my community, or this is what we're seeing as a stark comparison to some of the other communities that are near where I live. So let's think about this concept of place a bit more. And again, we wanted to just share a little bit and kind of get us thinking about this in relation to some of our own work before we dig into the framework. For a lot of us who are, either health educators or work in public health and so on, we want to be thinking about what health inequities exist in the communities that we work in. So using your text chat again, I want us to kind of reframe this to think about, instead of just what an equitable community looks like, what health inequities exist in the communities that you are already working with or in your community that you live in now. So if you can just use this time to kind of shout out via the text chat to state what some of those inequities are, what you see, what comes up for you, what might be new, what's been happening in your community for a long time. This would be a great time to kind of think about that before we jump in. So again, just use the next couple of seconds here to write that in, and I'll respond to some of the text that we see. I see a few folks writing in. Right, so one response was housing option differences, education opportunities, day care options, road access. These are all great, and all of those pieces are connected, even though sometimes we can't see those connections right away. Closing of grocery stores downtown, absolutely. We've been seeing this practice of suburban investment and the closing of urban stores and even in some of the rural communities for quite some time. Lack of public transit, absolutely. Access to transportation, access to health insurance, food options, grocery and fast food, that's another key piece. We oftentimes, the more fast food and unhealthy retail options we see, sometimes the supermarkets are further away, so there's lack of access to healthy food. So these are great options, and I think we also wanted to kind of follow this with a second question for you, and this one might be a little bit more challenging, and I'm going to go ahead and turn this over to Laquana.
Thanks so much, Maureen. I am excited about seeing all of the different options you all have sort of brought out in the text chat. And so the second piece of this conversation is really asking you all to think about how these inequities came to be in the first place. And so feel free to type in comments in the text box as well, and I'm going to talk through a couple of further slides. So in thinking about how these inequities came to be, it's important to note that over the last decade, health educators, practitioners, and advocates alike have started engaging in numerous efforts that address what we call the community determinants of health. And these community determinants of health promote and advance health equity. Determinants of health influence and shape opportunities to lead healthy lives and encompass a range of factors that include but are not limited to things like access to affordable housing, safe places to be physically active, equitable educational and employment opportunities, and of course the availability of healthy food retail options. And many of you have already called out some of these things. Public health practitioners play a critical role in addressing determinants of health through identifying and prioritizing strategic multi-sector actions to reverse inequities and promote a culture of health in their respective communities. And so in looking at some of the things that you all have added in, I'm seeing things like redlining, policies, laws like discrimination and racism, access to power. And so those are some of the things that we are going to be further discussing today as we get into the report. I wanted to start you off with a quote. Prevention Institute and Dr. Tony Eiten from the California Endowment prepared the report that is cited on your screen for the Institute of Medicine's Roundtable on Health Disparities to identify policy solutions at both the community, regional, and state level to reduce inequities in health and safety. And so this important quote states that health inequity is related both to a legacy of overt discriminatory actions on the part of government and the larger society, as well as to present-day practices and policies of public and private institutions that continue to perpetuate a system of diminished opportunity for certain populations. And so let's think about that in context as we sort of move through the Countering the Production of Health Inequities report. So at the request of the Robert Wood Johnson Foundation Achieving Health Equity team, Prevention Institute developed a systems framework to help practitioners understand the systemic production of inequities, as well as actionable pathways that shift from a focus on simply measuring those inequities to the actual intentional production of equity. So prior to this initiative, RWJF had developed its bold vision for a culture of health equity in which every person in the U.S. has the opportunity to achieve health and well-being. Staff and leadership from RWJF recognize that as a nation, we can't achieve a culture of health when there are inequities in health outcomes. So this vision was one of the drivers for developing this framework and resource. The framework provides a deep analysis of the 7 determinants of health that shape health outcomes and health equity and identifies specific sectors that have the opportunity to counter the production of inequities and produce equitable health outcomes. So of significance, it highlights the policies, laws, practices, procedures, all of the issues that are related to each determinant that have inadvertently or by design contributed to inequities in health outcomes for people of color and for people with low socioeconomic status. And in doing so, it identified 15 specific sectors that have played roles in producing health inequities. So we're going to run through a couple of the report findings from the RWJF report. And so a little bit about the process. Prevention Institute engaged in a multi-pronged effort which included the following activities of reviewing relevant documents, reports, and literature, conducting interviews, engaging in strategy and coordination discussions, as well as developing definitions for prioritized determinants and key concepts, and engaging external reviewers and synthesizing the feedback. So the AHE team at RWJF prioritized 7 specific determinants of health, which are listed here on your screen. And those are the environment, housing, public safety, education, employment, income and wealth, as well as access to quality health services. So the next finding really looks at the determinants of health and how they are interrelated and interconnected. And the truth of the matter is it's quite difficult to disentangle one determinant from another when it comes to health equity. They are connected through policies, practices, systems, and sectors, as well as through their impact on communities. So for example, a lack of public safety inhibits economic development in communities, which then affects employment, income, and wealth. And this analysis recommends going beyond a focus on a specific determinant or strategy within a determinant and compels audiences and users to engage in a systems approach to health equity. So in environments where multiple determinants interact to the detriment of health, the production of inequity may actually be accelerated and compounded across multiple generations. And then in looking at the third report finding, we know that the literature is abundant with data that documents inequities and health outcomes. And because of this, there's more written about the problems than is actually written about the solutions. And so there's a need to turn to practitioners and communities for direction on solutions. And this is consistent with a framework laid out by the Fostering Systems Change. And the analysis in that points to the need for systemic change, which goes far beyond what a specific program could actually accomplish. And the fourth finding here is that health inequities, of course, have been produced, and within each determinant of health, there are policies, practices, and laws and procedures, again, some deliberate, some inadvertent, that have contributed to health inequities across racial, ethnic, and socioeconomic lines. So from that, let's take a look at the 15 sectors we identified that have played roles in producing health inequities. And so while not every action or every individual involved in each sector has been part of the production of health inequities, it's important to understand that the various ways in which health inequities have been produced. And significantly, each of these sectors also has a critical role to play in producing health equity. So for the purposes of our conversation today, we're going to quickly walk through one of the determinants of health, which is specific to the built environment, and that is reflected in this report. So when we look at the 15 sectors, we can point to a number of sort of sectors here that contribute to inequities within the physical environment. And so the ones you see highlighted here are the ones that contribute to these issues, and that's things like banking and finance, business and industry, economic development, housing, land use and management, as well as transportation. So again, in thinking about the built and physical environment, we understand that as a result of multiple sort of overlapping and interacting policies and practices that govern the built and physical environment, some neighborhoods and communities in the United States have physical conditions that promote health, while others do not. And many of the circumstances in communities of color today are the result of historical land use policies and practices that have barred people of color from being able to live and work or spend time in certain neighborhoods. And so we like to use this visual to show how the gears work together for looking at policies and laws and practices and procedures that produce inequity in the built environment. So we're going to walk through just a few of the gears. Many of you are likely familiar with Jim Crow laws and the Plessy versus Ferguson case, which upheld separate but equal public facilities. And that was, of course, followed by the Jim Crow laws that further advanced the practice of prohibiting African Americans from existing in the same public spaces as their white counterparts. Things like zoning, where land use practices and zoning rules categorize white neighborhoods as residential, while communities of color, mostly African American or Latinos, were characterized as commercial, industrial, or mixed use. And these things have also contributed to inequities in health for the long term. There's also suburban investment and disinvestment in the urban core. So at the same time that there's public and private disinvestment from the urban core toward the second half of the 20th century, that was also mirrored by increased investment in and subsidization of suburban community development. And so investment in urban parks decreased, and the highways that were built as part of the urban renewal with funding from the Federal Aid Highway Act caused, low-income and communities of color to have their neighborhoods sort of cut through, and many of those urban parks and neighborhoods ended up having, divided families in neighborhoods where local businesses that were owned were then undermined. And then in looking at small business practices, the Small Business Administration in the 1980s actually encouraged liquor store ownership among mostly entrepreneurs of color. And this was because there was minimal capital that was required for business startup. Unfortunately, this fueled the higher density of alcohol outlets in communities of color and communities with low average household incomes. So these gears, are the gears in the previous slide, actually move together quite seamlessly to create inequities in the built and physical environment. And I think this image is really telling of the disinvestment that's occurred, and it's been fueled by historical and current day policies and practices. And many of you likely resonate with this image based on, maybe driving through a neighborhood. You can find these communities across the United States, or even in the community conditions in which you reside or work in. And like this image, we can see that poor zoning laws, small business practices, and disinvestment, like what we showed with the gears, has left many towns, like the one shown here, and cities with unhealthy retail options. And this is a significant problem that we find across the country. So in getting back to the report findings, we know that segregated communities are more likely to have limited economic opportunities and a lack of healthy food options and physical activity options. There's an increased presence of environmental hazards, substandard housing, lower performing schools. I think we could, go on and on. And while residential segregation has overall declined since the 1960s, people of color are increasingly likely to live in high poverty communities. And this does not negate the positive and protective aspects of people living together in cohesive communities, with communities comprised, for example, communities comprised of immigrants or a similar background. But when any group of people is living in conditions without opportunities for good health, such as folks living in highly concentrated areas or in deep poverty with multi-generational levels of poverty, segregation is not at all conducive to good health, especially over time. And in looking at finding number 6, 15 specific sectors emerged as key actors within the determinants of health, and in many cases, sectors have played historical and or current roles in the production of health inequities. In the 7th report finding, we see that things like bias, discrimination, institutional and structural racism, classism, all of these issues contribute to and exacerbate inequities in health, and they manifest in part as norms and shared values within sectors and institutions, which fuels the production of health inequities. Organizational norms construct the lens through which policies become practices, and workforces are then trained, and informal interpretations of these issues become decisions at the point of service. So in report finding number 8, we notice that there is a need for actionable solutions that will produce systemic change. And an analysis of the production of inequities, the potential roles and contributions of the 15 sectors we discussed earlier, and the need for actionable solutions were actually inform the development of the 10 priority multi-sector systems that can produce health equity at the community level. So while the impact of this can be felt and experienced at the community level, it will take actions beyond the community level, including at the local, regional, state, and federal levels. And in report finding number 9, there's a pathway forward to produce health equity by deliberately focusing on health equity. And this system provides a mechanism to employ rigor through intentional feedback loops and being intentional about sort of measuring change, which then promotes systems change. And with that, I'm going to turn it back over to Maureen.
Thank you so much, Laquana. So I just really love this image of a system of systems because it shows the connections and how we need to be really talking about equity and producing equity again in our communities. Through our analysis, we started to think about what we call a system of systems. And the metaphor here is the human body, which we know is comprised of the skeletal system, a circulatory system, a respiratory system, and so on. And this image, in this image, they're displayed separately here, but we know that they all interact and interrelate. And we started to ask ourselves, what do we do about these inequities that are happening, and how do we start to reverse it? And this led to the idea of a system of health equity. And so the way that we, define that is it's a way of organizing and structuring relationships, innovation, learning, and advocacy for coherent and interrelated practices within a foundation, government, private sector, and community to attain health equity across the population. And this definition is what starts to ground some of our approaches and thinking for how we start to articulate what a system of health equity is. And I just wanted to highlight the 4 Ps that we came up with as part of this analysis that we'll be lifting up today. And that is purpose, the intentionality for health and equity. The second one is people, ensuring and cultivating leaders and engaging residents, ensuring that there is a practice for health equity, having methodology and capacity that is sound, and then creating a platform, ensuring that there's infrastructure to support success that's sustainable and really kind of moving us towards systems change. And so let's go through each of these 4 buckets, starting with purpose first, the intentionality for health equity. The first principle here is applying a health equity lens. And this means that for each action, policy and laws, practices, procedures, there are questions that must be asked with different sectors and groups. And the first one is this producing health equity? It seems like a simple one, but something that I think a lot of us forget even when we're working in health equity. How will this achieve health equity? How is this, our goal, our initiative that we're working toward, appropriately accounting for culture, gender, power, and other important considerations? And will this counter the production of health inequities that have been happening in this community for decades and are happening and being perpetuated in the current day? The second principle is addressing bias, discrimination, institutional and structural racism, and classism. In order to change what we call these, sort of macro-level structures, intentionally focusing on practices of bias across multiple sectors and organizations can really start to be the way for creating momentum of awareness and being explicit around equity-oriented decision-making. For example, we know that there are a number of organizations and sectors that are starting to advance health equity by performing internal reviews of their policies and practices to identify these, quote-unquote blind spots that may be perpetuating differences in the treatment and outcomes of the communities that they serve. And that's been really effective. Thirdly, acknowledge the systematic production of inequities by accounting for community trauma. As Rochelle mentioned before, there's a lot of interest around trauma-informed care, and there's webinars and trainings that are happening around that topic. And so we know that trauma-informed care is becoming a standard in a growing number of places. And so far, even though this kind of framework and approach has been really successful, the predominant approach to dealing with trauma has been screening and treatment for individuals. And there's emerging evidence, even with that trauma, in fact, manifests at the community level. In high-violence neighborhoods, the belief that whole communities are traumatized is widespread. One community trauma framework that has gained a lot of attention and traction over the last 2 years since its development is Prevention Institute's ACER framework. This stands for Adverse Community Experiences and Resilience. And what this does is it helps move folks from thinking about trauma from an individual service-based perspective to looking at the community environment. And this framework has been used across a number of different issues, from violence prevention to childhood development to even looking at the community lens in terms of the opioid epidemic. And then fourthly, under this purpose bucket, we want to foster connections between people, systems, issues, and opportunities. These connections can be very tangible, like linking two program areas or grantees together, or can even be conceptual, as in exploring the connections between issues that haven't typically been linked. And we're seeing a lot more of that in public health lately in order to explore root problems and share and come up with shared solutions. Of the second bucket here, when we look at people in terms of leadership and engagement, we know that it's important to be creating a shared vision that galvanizes partners and holds others accountable. For those uncomfortable with health equity, leadership within the system of health equity will play a pretty instrumental role in understanding where there might be barriers, where they might be looking at metrics for determining opportunities for building bridges and reaching new audiences, as well as assessing where there might be collaborations that can yield certain benefits. We also know that it's essential to lift up community voice, participation, and leadership. This is something that's come up in a number of initiatives. A system of health equity moves from community as a recipient to community being at the center of these efforts. And it recognizes that health equity outcomes are not produced by formal institutions alone, and in fact, community engagement, participation, and leadership represent some of the key elements within a health equity system as voices of those traditionally underrepresented in leadership and decision-making, including youth, become elevated and become stewards of this system. And so the system of health equity ensures that there are things like training and capacity building efforts, as well as different frameworks available to support engagement, participation, and leadership by community members. And this image on the left, I think, kind of really speaks to this point. This is an image from our Policy Advocacy Day that we at Prevention Institute put on with a number of our partners. And the young man speaking is an advocate from Planada, California, who is at the state capitol advocating for a Safe Routes to School bill to make his community safer. He was brought to the Capitol through an advocacy day, as I mentioned, where we were able to then provide training for conducting legislative visits around these select bills that would make his community healthier and more equitable. So there's that training piece in addition to being able to cultivate leaders as part of that movement. And then there needs to be practice in place for a system of health equity. And the first approach here is developing tools, approaches, and methodologies for developing practical and actionable health equity initiatives. We know that there are many different federal agencies as well as foundations and nonprofits like Prevention Institute and our partners that are supporting groups through the development of tools and frameworks and methodologies for making health equity work practical, which is a key lever of the system of health equity that we're talking about. We also know as part of this, it's important to have trainings and organizational capacity building efforts, like I mentioned with the example from the young man from Planada, California. There's a need for this to build systems and sectors to foster collaboration. And it's not only about building skills, but it's about shifting cultures and norms within and across these sectors and systems as well. And so here's just a few of the kind of key points that should be really a part of these training efforts, which is fostering collaboration, advancing comprehensive approaches, actively engaging in multi-sector systems, and of course applying that health equity lens. And then lastly, it's essential to develop a platform, and to do that, we start with communication strategies to make the case for developing a shared health equity language among diverse sectors. Related to this training and capacity building piece, we know that making the case does require skill building of participants within this health equity system so that they're able to feel comfortable talking about health equity in relation to other key values and developing that language to integrate health equity among sectors. And this is particularly useful for those who are not yet at the point where they can embrace their role in fostering health equity, and I think this comes up among a lot of our different partners. And so this should happen among lots of different communication channels, and I'm sure many of you can kind of think of those communication channels that work with your community, and this can span from social media to engaging with public officials and other media platforms within the public sphere. And then diversify financial investments and incentives across multiple sectors to reduce ongoing production of inequity and sustain the production of health equity. One premise of this system of health equity is that issues and sectors are interconnected. Yet at the same time, even though we know this, funding for health, particularly from the public sector, can still feel often isolated. I know a lot of us sometimes feel like our work is in silos. And so there's a need to diversify resource and financial investments and incentives across multiple sectors and remove these funding silos and build partnership for long-term investments in community change. So additional financing tools are also needed, and this can include things like incentives and rewards for cross-sector collaboration. This can include new sources of capital, such as tax credits and socially motivated investments by foundations and different investors, and tools to finance the operations and innovation of organizations and partnerships rather than only those programs and projects alone. And so financing tools could have a much greater focus on things like innovation and learning with flexibility for creative risk-taking at the same time. And then lastly, develop metrics to measure health inequity at all levels with a particular focus on determinants of health. So establishing metrics that measure and track our progress on the determinants of health can help us really be able to set priorities and inform necessary actions that we know will make a difference for our community in terms of health and well-being of our populations who are most at risk for poor health and safety outcomes. And there's a lot of different metrics out there that look at the determinants of health. I know at Prevention Institute, a few years ago, we worked with the Robert Wood Johnson Foundation's Achieving Health Equity team, as LaQuana had mentioned earlier, and we developed a priority set of recommended health equity metrics. And these are intended to be used to measure progress toward achieving health equity related to the determinants of health, as well as structural drivers and healthcare. So I'm going to turn it back to LaQuana. I think that gave a really good sense of what we mean when we talk about our system of health equity and some general principles to follow as it can relate to your own work. And we want to showcase a couple of examples of communities that have really embraced a system of health equity and built that into their practices.
Thanks, Maureen. So I'm going to walk us through two community examples that hopefully help to sort of uplift a lot of what we've been discussing today. And the first example here is from the Community Farm Alliance, or otherwise known as CFA. So for the Community Farm Alliance, the health and prosperity of Kentucky's urban residents is inextricably linked to a thriving rural economy. And so using a blend of economic development and youth development and input, as well as community development principles, CFA sort of promotes the sale and consumption of food grown by rural family farmers. And so the group aims to increase access to healthy, affordable food throughout Kentucky, including in urban and African American communities. And the organization's state-level policy advocacy targets institutional and financial levers to create a more favorable market for rural farmers. So for example, CFA is working to create incentives for neighborhood corner stores to carry Kentucky-grown produce, and this has helped them to launch a number of programs in local farmers markets that help to improve urban food availability. And two CFA farmers markets located in Louisville communities that have a low average household income serve about 8,000 people a year. And these strategies have enabled CFA members to help enact 24 pieces of legislation to support, or in support of Kentucky's farmers and the rural and urban communities that actually depend on them. And so through this mission, CFA was successful in shepherding preferential purchasing legislation. And this legislation actually mandates that all state government institutions purchase from local growers whenever possible. The other image that you have in front of you and community group that we wanted to highlight was the Park Development and Community Revitalization Act. And so the completion of this happened through a $6.9 million renovation at Bayview's Hilltop Park, which was funded by the statewide Park Development and Community Revitalization Act of 2018. So prior to that, in 2006, California voters enacted a bond measure which allocated $400 million to improve access to parks and recreational facilities, specifically in California's urban areas. And then 2 years later, then Assemblyman Kevin DeLone worked with local advocates in Los Angeles to author Assembly Bill 31, which was the statewide Park Development and Community Revitalization Act of 2008. And this act steered the funds that have been allocated in 2006 towards communities with the greatest need for increased access to green space. And AB 31 also specified funding preference for new parks and communities that were identified as critically underserved and had no parks in their neighborhoods, and where applicants had actively involved community-based groups in the planning process. So language was also included that referenced the health and social benefits of parks and the fact that many underserved neighborhoods also experience poor access to those parks. And in addition to AB 31, it also included provisions requiring the grant program to offer technical assistance to all potential applicants. And this provision really helped to address some of the key barriers that would have otherwise discouraged applicants from applying in the first place, specifically in cities with smaller populations who have a lower average income and have limited budgets and staffing, as well as competing priorities that present obstacles to taking on new and innovative projects. And so grant-specific technical assistance helped to build the capacity for these organizations, which allowed these entities to compete with jurisdictions that have historically had access to more resources and park development and expertise, largely due to their larger population status as well as affluence. And as a result of the equity-focused provisions that were built into AB 31, $400 million was invested into 127 neighborhood parks that previously had insufficient or no parkland available at all. And so with that, we wanted to pause for just a second to open it up to any questions you may have and any answers we can provide, and then we will follow that up with pointing you in the direction of some of the resources that you can find online. And Maureen, I'll turn it back over to you.
Thanks, Laquana. And so we also just wanted to mention that, within an hour, we recognize that it's not a lot of time to really dig in and digest some of the material that we're introducing. And so we do encourage you to kind of look through some of the resources that we'll point you to, but just know that during this time, if there are questions that you have or things that we can help clarify that maybe wasn't clear, we kind of sped through in the time that we have, we're happy to answer some of those questions through the text chat. So we'll go ahead and give you just a couple of minutes to kind of to think through what those questions are, and in the meantime, while folks are typing in questions or kind of thinking about if there's anything that they would want to ask, we just wanted to point you to some of the resources that we referenced today. You can find these on our website. The major report that we referenced is Countering the Production of Health Inequities. As Laquana mentioned, this was supported by the Robert Wood Johnson Foundation and was developed and kind of put out around a year and a half ago. And if you were to go on our website and go under our Health Equity tab, you can find this publication and download that. I know for us at Prevention Institute and some of the work that we do and communities that we support, I have this printed out and I continue to reference it as much as I can. It's just a really helpful tool. And then the other publication that I wanted to just briefly mention, which was in follow-up to our major Countering the Production of Health Inequities publication, is Ensuring the Opportunity for Health for All. And this was just released a few months ago. This kind of gives some tools and some visuals and frameworks of how to articulate the determinants of health in relation to a system of health equity. So this might also kind of help with some of the information that can be harder to digest and that can feel complex. This is a great way to kind of summarize and capture that. So with that, we'll keep the line open if there's questions, if you want to use the text chat for that. Otherwise, we'll go ahead and turn it back to Rochelle.
Thanks so much, Maureen and Laquana. A lot to think about and a lot to digest. And we do welcome your questions and comments, especially if there's ideas for future topics for Health for a Change. If there's something you're interested in taking to the next step, I welcome your ideas for Health for a Change. Here you can see our lineup through August. You can also check our website, healthy-ky, for all of the archives and slide decks from our different Health for a Change trainings. I do invite you to please contribute to the post-event survey. I'll send that out via email here this afternoon. It only takes about 3 minutes on average for you to give the feedback on our webinar today, so we can improve things and hear what you liked about the webinar and what webinars you'd like to have in this year. Thanks to all the participants on the call today. Feel free to check out our website, healthy-ky.org. And again, this is Rochelle Seeger. I'm honored to work with you all in working to improve the health of all Kentuckians. Thank you so much for being on the call today.
This concludes today's conference. Thank you for your participation. You may now disconnect.